Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer. It's been working with CCF for 10 years, over 10 years. In fact, I think it's 11 now, to create video series like this. We do documentary style, patient-centric videos. We do treatment-based videos. Lots of work we've done over that 10 years. And you can see that database on our YouTube channel as well as here on the Facebook page under the videos tab. But they all have the same mission in mind, and that's to educate people about neuroendocrine tumors. That's what we're here to do. And this show, specifically with Luncheon with the Experts, I think does a really good job of that, educating people. And also, we've cultivated and created this community that I think is really powerful and just as valuable when it comes to support, when it comes to sharing experiences and stories. And if you're new to the show, new to this journey, I highly encourage you to embrace that community. They will embrace you. So one way you can do that right now is just by introducing yourself in the comments section. Say hello, tell people where you're from. If you see the comments, you see that the regulars to the show are already doing that. We've got Ursula from South Africa. We've got Laura from Wisconsin, a couple of people from Wisconsin, actually. I love to see how far these programs reach. Every week, it is surprising to me. I see Melbourne in the house. See there, every week I see countries that should be asleep right now, and people are tuning in live. So that tells me that we're doing a great job. So before we get started, we always want to thank our sponsor, Ipsen Biopharmaceuticals. Without their support, folks, we wouldn't be able to do the show. And we have a disclaimer from them, and that is that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatment. So that last line is really the takeaway there. We're going to give you some good advice and answers to your question, but we don't know your specific case. Take that back to your home team that does, and make the best plan and path forward for you. Because as we know, every case of this disease is unique, and therefore every plan and path forward is as well. Today, I'm very excited, and the numbers reflect that you are as well, to welcome back Dr. Jonathan Strosberg, who has been on the show before, and we have worked together a couple of times. Actually, I've been to him with person for a video, and we've had him on the show, and he was I'm pretty sure one of our top 3 shows in terms of attendance. So his reputation precedes him. How are you, Dr. Strosberg?
Good, thank you.
So for those who may have missed that first episode we did, or may not be familiar with your work, can you tell us a little bit about what you do specifically, where you work, and what role you play in the NET community as you see it?
Sure. I'm a gastrointestinal oncologist, a professor at the Moffitt Cancer Center in Florida. I'm one of the few doctors, I think, that treats exclusively neuroendocrine tumor patients. We also have a lot of research and studies in neuroendocrine tumor field, and I serve as president of the North American Neuroendocrine Tumor Society.
Yeah, folks, that is an interesting point you made about, because a lot of our doctors have plenty of experience with NET patients, and many of them, the majority of their patients are NET patients. But it's very interesting that that's exclusively who you work with these days. So folks at home, and I can see by the numbers that people are excited for this show. You're going to get a lot of value out of this. And I want as many people as possible to get the value out of this. Dr. Strosberg, it's almost minimalizing it to say like he knows this stuff. Like, it's going to be a great episode. You're going to get a lot of good information. So what would help us and help everybody else in the community, if you know someone that should be here, because the real value is being in this interactive session and getting a question that you've been struggling with, getting that question across to Dr. Strosberg, tag them in the comments. You can share the video to their page. Just let them know the show's going on. Of course, you can watch the replay here on Facebook. Starting Monday, it'll be on YouTube, and there's a lot of value in that, but I really want people to get their questions across. So you all do a great job of that every week, and it helps get people here. The other thing you do a really good job of, but I will always reiterate because it helps me, is if you see a question in the comments section that you also have or you're interested in the answer to, right under the comment, there is the option to like it. And if you hover over like, it gives you lots of, you can love it, you can whatever. All the emojis effectively work the same way for me, and it shows me there's a demand for that question. And because inevitably we get so many questions, we can't get to them all in 1 hour, that will upvote those questions, and I'll make sure to get them across. If 7 people have the same question, I know that's a very important one for us to get to. So thanks for your help doing that. Go ahead and start sending in your questions. Dr. Strosberg, when did that, I'm assuming, so correct me if I'm wrong, that you didn't start off your career serving only NET patients. So at what point did that change and why?
That's true. So I basically was influenced to really develop an interest in NETs by my mentor during fellowship, Dr. Larry Coles, who was really one of the giants in the field and the first doctor to study somatostatin analogs in patients with octreotide back in the 1980s. So I started off my my career seeing a lot of NETs, but over time that number increased. And when Dr. Coles retired around 2012, around that time, the practice became so busy that I started seeing pretty much exclusively NETs. And I still have, a small number of patients with other cancers who have continued to see me over the years, but at this point, it's almost exclusively NETs.
And that was 2012, you said?
More or less.
Yeah. In that time, which is crazy, that's 10 years now. I keep thinking it's still 2020. Tell me a little bit about the progress that you've seen be made in terms of treatment options, in terms of diagnosis, in terms of knowledge of this disease.
Right. Well, huge amounts of change for treating patients with advanced disease. Back in the 2000s, really the main treatments were somatostatin analogs. Interferon was still used. Beyond that, liver embolization. And then around 2010 is when drugs like Afinitor and Sutent were FDA approved. But it wasn't until 2018 that ludithera, the radiolabeled somatostatin analog, which had been used in Europe for a number of years before that, but never formally approved. So it wasn't until 4 or 5 years ago that we really were able to start using radiolabeled somatostatin analog, ludithera. That's made a big difference.
Absolutely.
And there have been a lot of other drugs that have been studied in the meantime. We're expecting a new drug, surifatinib, to hopefully be approved later this year. So and then others after that. So
it's good news.
Telotrestat as well for carcinoid syndrome, that was approved more or less 2017.
Now, I know you're also involved in a lot of clinical trials. Are there any that you're working with or on currently?
Yeah. So we're involved in the CABINET study of cabozantinib. It's a very large randomized phase 3 study looking at a new tyrosine kinase inhibitor. I'd say showing significant promise. We have a study of lenvatinib and pembrolizumab, so a combination of a targeted drug and immunotherapy. We're involved in a liver embolization trial comparing chemo and bland embolization. And there are several others as well.
Awesome. And folks at home, what we'll try to do, we have Grace Goldstein working on the back end. We will try to add links to the trials that Dr. Strosberg is working on, publications from him, et cetera, and anything that he references today. We'll try to add that link into the comments section, so you don't have to try to be like, oh, what did he say, and open another browser window and find it. We'll try to do that work for you. That's our job. So Dr. Strosberg, lots of questions coming in already, so I'm going to go ahead and pivot to the audience. First one is from Cade. Question from the network member: will PRRT be improved for patients that are at risk for bowel obstruction?
Right, that's a good question. So I think we were actually the first to point out that patients with extensive peritoneal disease, especially to a lesser extent extensive mesenteric disease, seem to be at risk of bowel obstruction with PRRT. And so what we started doing is sort of rating the extent of peritoneal disease and using that to either not treat patients if they're at excessively high risk, or if they're at moderate risk, to use prophylactic steroids. Whether prophylactic steroids are really effective at preventing Bowel obstruction is hard to say. Theoretically, we think they might by reducing the amount of inflammation associated with PRT, which can cause the tumors to sort of stick to the intestine. And we found that steroids are sometimes effective at managing this once it occurs. So we think that prophylactic steroids do help some patients who are at moderate risk. But it's unclear whether the newer generation of agents, such as alpha emitters, are associated with the reduced risk of this complication. It's just way too early to say.
Got it. Hey, thanks for your question, Kate, and it's good to see your name again. I think you were relatively.
But it's an important point, though. I mean, the more important point is that patients who have extensive disease in the peritoneum, around the intestines, it's important to share this with whoever's considering PRT, because it could create problems.
Got it. Thank you so much. Next question comes in from Reese. Reese says, my primary is on the tail of my pancreas, and I'm having a meeting with my surgeon next week. My radiologist said that he may want to also remove the gallbladder and spleen. Any thoughts on that, or things that Reese should be considering before he heads into that meeting?
Right. So when you have a primary tumor in the tail of the pancreas, the conventional surgery, which is a distal pancreatectomy, typically also involves a splenectomy. And a surgeon can explain the rationale for that better than I can, but it has to do with the shared vasculature of the pancreas and spleen. It's simply less risky in most cases if you remove the spleen along with the tail of the pancreas. The gallbladder removal is probably based on the notion that you may require somatostatin analog therapy in the future, and therefore somatostatin analogs are associated with the risk of gallstones. So doctors will often remove the gallbladder if they're in there already to try to prevent that risk.
Got it. Thanks for your question, Reese. Hopefully that helped. And folks, if you have follow-up questions and you're still on the call, please feel free to message us later. Give me a little information about your previous question so that I can remember who it was from. And if we don't get to it and you still have follow-up questions, I encourage you to message CCF either here on the Facebook page, or you can visit them at carcinoid.org. We really want to try to get you the answers to your questions and get the information you seek. Next question, Dr. Strosberg, from Jennifer and a few others. How long does it usually take lenriotide to work? I'm 7 months in and it's not helping a lot. So I sense some frustration here.
So the question is, what does it mean to work? Because that can mean several things. If you have a hormonal syndrome, and particularly carcinoid syndrome, which is the most common, lenriotide usually works pretty quickly, meaning, within the first couple of days or week of treatment. If people have flushing and diarrhea related to carcinoid syndrome, that usually gets better. Of course, in many cases, lenriotide is designed to or is given not to control carcinoid syndrome, but to simply inhibit tumor growth. So if your symptoms are unrelated to carcinoid syndrome, for example, if they're related to, say, pain from tumors, lenriotide is not going to help with that. It's simply going to, in some cases, stabilize the tumors, not always. So I guess it does mean, the question really is what are the starting symptoms? Now, it's important to emphasize lenriotide also has some side effects. All somatostatin analogs do. So it can cause diarrhea related to malabsorption, pancreatic malabsorption. It can cause abdominal cramping. So sometimes patients will have diarrhea from carcinoid syndrome. They start lenriotide, the diarrhea from the carcinoid syndrome will get better, but they'll develop a different kind of diarrhea, which can be treated with pancreatic enzymes such as creon. So it's a little bit of a complicated question. It would be interesting to know what the symptoms were to start with.
Gotcha. Thank you. All right, next question from Barney. Barney says, hello from Seattle. Can a lab use specimens from an extracted neuroendocrine tumor to determine if they had secreted cortisol or other hormones before the person's surgery? Before
the person has surgery?
That's what it says here.
Oh, no. Okay. So after surgery, you're looking for the specimen, but the question
to see if it's secreted. Yeah.
Not really. You can stain for certain hormones, and there may be a little bit of a correlation between what you're staining for and what the cancer produced, but it's not a clean correlation. The best way to know whether a hormone is being produced is to do the blood test for that hormone.
Got it. Thanks, Barney. I think your name looks a little new. Pardon me if you've been here before, but if you're a first timer, I want to say welcome. But thanks for your question regardless. Next question from Sherry and a few others. Hello, is proton therapy a viable option for lung nets?
I'm not really an expert on proton therapy. Proton therapy is another form of radiation, external beam radiation, that's uses a completely different type of energy, protons, rather than X-ray beams to treat a tumor. A radiation doctor would give you a much better sense. I can tell you in general that proton therapy is much more, it's much more expensive. It relies on extremely expensive machines, and it's primarily indicated for certain types of cancer that are harder to treat with conventional radiation. And there are also different types of conventional radiation, by the way. So whether there's an advantage is debatable. Right now, it's typically approved only for certain types of relatively rare cancers.
Got it. Thanks, Sherry. And I just wanted to make a point. This is a blanket statement as well, but specifically referring to last week's show, we had Dr. Daniel Lee on, and we discussed a couple of times things like that. And in general, I wanted to say that we have covered almost everything in all of these shows and the other videos that we've done. So I would encourage you to look at all of that database, but specifically for your question, you might find the answer. And I don't recall exactly what he said, and I don't want to misquote him, but I do remember we were talking about those sorts of therapies. So that might be helpful in where you could find your answer. Next question from Lynn regarding PNET tumor with DAXX gene mutation, metastases to liver. What is the best treatment, and is there ongoing research for either repairing this gene or treatment for this type of tumor?
Right. So there are certain mutations that are typically associated with pancreatic tumors. MEN1 can barely be hereditary, but more commonly somatic mutation in about a third or 40% of patients. Then the next most common are either DAX or ATRAX that are also associated with chromatin remodeling and occur in about a third of the patients. And then a relatively small percentage are associated with the mTOR pathway. So at this point, there's nothing really specific for DAX mutation, nor are there any therapies that are designed to repair it. It's there's no evidence that DAX mutations render a tumor particularly susceptible to a particular type of treatment.
Got it. Thanks for your question. Lori has a question that I'm sure others do as well. What are your thoughts on ludithera versus alpha PRRT in terms of efficacy and side effects?
I mean, it's way too early to say. All we can say is that there's really exciting looking data with alpha therapy coming from institutions such as Radiomedics in Houston and some other places. So there's going to be several trials. One is looking at lead 212 dotamtate. Lead is an alpha emitter, and then we may see other trials using actinium. There's been some early data reported from India, and it looks like the response rates are quite high.
Good.
Alpha therapy basically is 2 protons and 2 neutrons, as opposed to beta emitters, which are electrons. So it's a much higher energy particle delivered over a much shorter range. We're hoping that it's more effective than lutetium dotatate, but it's too early to say.
Got it. Thank you for that, Dr. Strosberg. Folks, if you joined us recently or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We're here today with Dr. Jonathan Strosberg from Moffitt Cancer Center, and A lot of great questions coming in already. We're going to keep moving forward. From Sharon, is it common for the primary location to be unknown? And also, do some NETs not show up on scans, including the gallium 68?
Well, techniques, it's becoming less common. Not all tumors express somatostatin receptors, so the dotatate scans, whether you're talking about gallium 68 or copper 64, are not perfect. They'll identify the large majority of well-differentiated tumors. Poorly differentiated carcinomas tend to be somatostatin receptor negative. And I suppose, therefore, a known primary, poorly differentiated neuroendocrine carcinoma would be more common than well-differentiated. Often it's, even if we, the small bowel tumors, which are the most common primary tumor for well-differentiated NETs, can be really small. But if you have carcinoid syndrome, if you have a mesenteric mass, those are all signs that you're dealing almost certainly with a small bowel primary, even though it may not be seen on scans.
Got it. Next question from Stacy is about carcinoid heart disease. Are you comfortable taking a question?
Sure.
In that field? So it's pretty simply, how do you evaluate a patient with carcinoid heart disease, and what is your treatment protocol?
So carcinoid heart disease occurs in patients with carcinoid syndrome and elevated levels of serotonin, whether you measure it in the blood or in the urine as 5-HIAA. Usually highly elevated levels of serotonin, meaning more than 4 times upper limit of normal, and over a long time. And the higher it is and the longer the heart valves are exposed, the more likely you are to develop it. It's a problem that typically affects the right heart valves, tricuspid and pulmonary valves. And there are different guidelines on whom to screen and how to screen. But basically, you want to identify people at relatively high risk. So at the very least, elevated 5-HIAA or serotonin. And you can either, first physical exam for a murmur, but beyond that, there's echocardiograms, which are often done once yearly in at-risk patients, or a pro-BNP, which is a blood test that looks for early signs of heart stress. We tend to rely mostly on echocardiograms. So you want to look particularly at the tricuspid valve for evidence of regurgitation. But if someone, sometimes this can develop quite quickly. So if someone with carcinoid syndrome starts developing leg swelling, shortness of breath, difficulty with exertion, those are all signs that carcinoid heart disease might be developing and should be evaluated.
Got it.
Important that if you have carcinoid heart disease, or if there's a strong suspicion that the cardiologist that does the echocardiogram be someone who's familiar with carcinoid heart disease, and then that, you're seen by a heart surgeon who has expertise in this.
Got it. Thanks for your question, Stacy. Next question from Dixie. What would you suggest if someone's serotonin is still high while being on both lenriotide and Zermelo?
Well, I guess it depends on how high it is and what the serotonin is causing. So serotonin is the hormone that's produced primarily by small bowel metastatic neuroendocrine tumors. It's one of the hormones that's responsible for carcinoid syndrome and carcinoid heart disease. It's typically reduced by the somatostatin analogs quite significantly. Zermelo is indicated particularly for refractory or suboptimally controlled diarrhea related to carcinoid syndrome. So if you're having significant diarrhea on a somatostatin analog and your serotonin is elevated, then that's what Zermelo is indicated for. Now, it's important also to remember, though, that any blood test can be associated with false positive results. And particularly serotonin is often associated with false positive results. So the preference is to do a urine 5-HIAA, although some places are doing blood 5-HIAA. And it's important to adhere to the dietary restrictions before checking serotonin or 5-HIAA, so that to maximize the specificity. So there's certain foods, and particularly foods, sometimes drugs, that should be avoided for at least several days before the blood or urine collection, to make sure that it's not artificially elevated.
Got it. Thanks, Dixie. From Marnie, is there medication to treat abdominal cramping as a side effect from lenriotide? A lot of people experience that, it seems.
Cramping particularly, not so much. I mean, there are antispasmodics like Bentyl that you can consider. But if you're having problems with lenriotide and you feel that it's related to the drug, then you can always try sandostatin, octreotide, see if that makes any difference. Usually they're quite similar, so usually doesn't make a big difference, but you can always try that.
Okay. Next question from Jeannie. Jeannie. It's a little bit specific, but I think we can navigate this. Are you moving to advising PRT earlier in a stage 4 PNET disease treatment sequence for patients who have had a distal pancreatectomy and liver resection, who are younger, like in their 50s, or is it better to try Afinitor and liver embolization and maybe Captem first?
Yeah, that's a tough question. I mean, the bottom line is we don't know how to sequence these different interventions. So the range of treatments that have been evaluated or approved for pancreatic neuroendocrine tumors includes Afinitor, Sutent, Captem chemotherapy, PRT with ludithera, and then there's liver embolization can be used for patients with liver dominant disease. And very, very difficult to know how best to sequence these. There's a trial, the COMPETE trial, that's looking at lutetium dotatok versus everolimus. That's a trial that's open in our institution. Almost completed enrollment, and maybe that'll give us some sense of how these two of these options compare to each other. But I don't have a great answer, and I don't think anyone does, as to how to best sequence. But if the tumors are progressing and express the metastatin receptor strongly, I think PRT is a very reasonable option, and certainly one that's associated with a good quality of life for almost all patients. It's not something that needs to be taken on a daily basis. It's only 4 treatments. Mm-hmm. So you can make a good argument to start with PRT if the disease is progressing.
Got it. Well, speaking of quality of life, our friend Wendy says, "Hi, Dr. S. You gave me the quality over quantity speech about 5 years ago, and I'm still here. However, quality is not so good. Sorry to hear that, Wendy. Sending you love." And the question is, how long do people typically survive after a Whipple operation, which she had? I'm not sure when, but what's the prognosis usually?
I mean, it depends what the Whipple was done for and whether there's active disease after the Whipple. So, any advice that you can give her, things she should be focusing on? Yeah, I know we're not sharing last names, so I'm having a hard time recalling the specifics. But just Wendy, I would encourage you to reach out, after this conversation, and we can go over the specifics.
Okay, Wendy, there you go. And I'm sure Dr. Strosberg will be able to help. Okay, Dorothy says, here in Canada, we are changing Novartis octreotide to a generic, and I've been on sandostatin for 6 years, and I'm doing well. So I'm nervous, but should I be?
Well, I hope not. I don't know too much about generic sandostatin. I mean, the drug has been off patent for a while. One hopes that generics are manufactured with the same level of quality as brand name. I mean, that's generally the case.
Got it. All right. Moving along. Lynn says, is there a way to repair mutated genes? And if not, is this an area of research?
So repair of gene mutations is kind of a very, I mean, this is very early days. There are certain hereditary conditions that are nowadays starting to be treated with gene therapy to repair mutated genes. Not really something that's yet been ready for prime time in cancer. And once cancer has spread, being able to repair, and they accumulate mutations, many mutations in some cases, being able to fix all those mutated genes, I'm not sure if that's really feasible in the short term. So the bottom line is, from almost all cancers, and specifically for neuroendocrine tumors, that's not currently a feasible treatment.
Got it. Thanks for your question, Lynn. Next question from NETS Mexico. Good to see you all here. Hello, is there any relation between carcinoid syndrome's symptoms, triggers, and tumor growth? And do amines promote tumor growth?
Right, not as far as we know. So there's no evidence to suggest that.
All right. Thanks for your question. If you have anything else, let us know. We're about halfway through, folks. So we got about 30 minutes. Great questions today. Next question from Allison. The symptoms of carcinoid syndrome, i.e. flushing and diarrhea, are also that of mast cell disease causing high histamine levels. Is it possible to diagnose carcinoid syndrome without identifying the primary tumor?
It's a good question. Obviously, in the vast majority of cases, when you have carcinoid syndrome, you can identify disease, not necessarily knowing where it originated, but there is some evidence of disease. There are patients who have symptoms that mimic carcinoid syndrome, or that appear to be carcinoid syndrome, but with no evidence of disease. And when there's no evidence on good quality CAT scans or MRIs, and on things like a dotatate PET, it's hard to ascribe it to a neuroendocrine tumor. Now, if we've seen cases where the patients have symptoms, the urine 5-HIA is elevated, but there's no evidence of disease. And sometimes we'll even start patients on a somatostatin analog, but these are very, very few and far between. So in most cases, I think it's something else that's causing it. It could be mast cell disease, although that's quite rare.
Mm-hmm.
It could be some dysregulation of the autonomic nervous systems, like POTS, postural orthostatic tachycardia syndrome, which is a poorly understood condition that can mimic carcinoid syndrome.
Got it. Thanks for your question, Allison. Next question from Sonia. What lab results, if any, will indicate that sandostatin LAR 30 milligrams is no longer working? My oncologist has indicated this will likely occur in the next few months, and flushing and diarrhea has been stable for about 12 months.
So, when we're looking at patients with metastatic neuroendocrine tumor and hormonal symptoms, we typically follow scans, because one of the goals of the somatostatin analog is to control tumor growth, and typically the hormonal marker, which could be, for example, 5-HIA. There are other non-specific blood tests. When I say non-specific, I mean non-specific for a particular syndrome, such as chromogranin, pancreastatin, substance P. There's the NET test. So there are other circulating markers that can indicate whether treatment is working or not. We tend to be relatively conservative and rely mostly on the scans and the hormones, but there are others. Just bear in mind that the more blood tests you look at, the more likely things are to fluctuate, and things can sometimes be misleading.
Got it. Thanks, Sonia. From Suzanne, could a 5-HIAA of 157 be from being on Zoloft? My doctor had me titrating off Zoloft and I will be and will repeat the 5-HIAA. I have carcinoid syndrome symptoms.
Well, antidepressants generally don't raise 5-HIAA significantly, and that's, if you're talking about 155 milligrams, that's a pretty high number. So if you have the syndrome and the very elevated 5-HIAA, it sounds like there might be underlying disease that you should be able to pick up in the scan, but it's not 100%.
Got it. Thanks, Suzanne. Hopefully that helped. And if not, go ahead and chime back in. Next question from Becky. Are there any herbal supplements to avoid with PNET or liver mets, and liver meds rather?
Well, that's a tough question because there's almost an unlimited number of supplements, and we don't.
Right.
I certainly don't have information on most of them, either pro or con. So it's the answer is most of them are probably safe. We just don't know what effect almost all of them have. Likely none, but that's not something a doctor will generally be able to answer.
Yeah, understood. From Skip, how broad would the use of surifatinib be?
Well, I'm not sure I understand the question completely, but surifatinib is a drug that was developed in China and studied in 2 phase 3 studies in China, one in pancreatic NETs and one in non-pancreatic NETs. Non-pancreatic NETs, by the way, in China typically means rectal, lung, thymus, but notably absent small bowel midgut NETs that are more prevalent in the West. So it was relatively aggressive non-pancreatic NETs, but the bottom line is it showed benefit in both the pancreatic and non-pancreatic population. And if it's approved, it'll likely be approved for those populations. Okay.
Hopefully that answers your question, Skip, but if you have anything or any more clarity, let us know. From Lynn, I read there are 5 markers that can be found by a blood test to see how effective PRRT will be. Is this going to be standard practice?
Well, I don't know about 5. I mean, there is something called the PRT predictive quotient that.
Yeah, she mentioned that. Yeah.
Sloan Kettering, and is being tested. We're actually participating in that to try to see whether it helps predict who will benefit. But it's not yet a standard of care.
Got it. All right, folks, we got about 20 minutes left and lots of questions coming in, so we're going to keep it moving. Jennifer says, I am a 35 plus year survivor of neuroendocrine cancer. Awesome to hear, Jennifer. I've completed session 3 of my second round of PRRT, 2018, and then here recently from September. I was told that I could tolerate 1 more series at some point. Your thoughts? Europe does 4. And I know that we typically do 2. And then follow-up question, what are your thoughts about immunology, proton alpha particle treatments, which we've kind of touched on? But let's stick with the how many sessions or rounds of PRRT you would suggest, or is that 1 more appropriate, or could it be?
Experience that was developed over years at Erasmus Hospital in Rotterdam, and became the basis for the NETTER-1 study. Mm-hmm. In Rotterdam, where they have the largest experience, what they tend to do is for patients who have benefit with the first round of 4, they tend to give an additional 2 cycles and then an additional 2 cycles later on if they need it, and they cap it at 8. Other institutions do things a little bit differently. Some institutions base number of cycles on dosimetry, although it seems to me that we don't have a great way of using dosimetry to predict how many cycles a patient will tolerate. Much of it is pretty crude. And you know, whether 8 is really a maximum is also something that's not really well established. I'm sure it is for some people. For others, they can do well over 8. So we don't have a great answer to that question. All we can say is that you almost certainly can treat patients beyond the first 4 cycles if they've derived at least a year of benefit. But you know, whether to do it in groups of 2 or in groups of 4, whether to stop at 8 or to continue beyond that is not clear. Now, as with all treatments, the more you give it, the less you're going to benefit from it. So the benefit for the second round is about half as much as the benefit from the first round, which is not surprising. Cancers become resistant to treatment over time.
Got it. From Anna, can lenriotide and octreotide cause a person to gain lots of weight? A few other people were interested in this.
Not really clear. I mean, both drugs can impact certain hormones such as thyroid. So, you know, you could speculate for, you know, if you have weight gain on lenriotide, it wouldn't hurt to check thyroid hormone. You know, there may be other hormonal changes that lead to weight gain. You can also get weight loss from malabsorption. In general, you know, my experience is that in almost all cases, it hasn't influenced weight.
Got it. From our friends again in NETS Mexico, is it common for NETs to increase in grade? We've had this question before.
I'd say fairly common over time. Perhaps more with pancreatic or lung NETs than with small bowel NETs. But yes, over time, the tumors can become more aggressive. And if you were to re-biopsy them, you would probably see a higher proliferative index.
Thank you again, NETS Mexico. From Allison, haven't heard about this in a while, but we have had many questions. Is the NET test valid for the diagnosis of carcinoid syndrome?
I don't think the NET test is specifically designed for carcinoid syndrome. I mean, it is designed for picking up evidence of neuroendocrine tumors. I'm not sure if I would recommend that it be used as a diagnostic test, though. I mean, you can get false positives, and it seems to be less specific for, you know, if you're trying to distinguish NET from another cancer, for example. It's not as specific as trying to distinguish having neuroendocrine tumor versus not having cancer at all. But no, it's not specific for carcinoid syndrome.
Got it. Thank you, Allison. And just a reminder, I've kind of said this to other people. We have lots of videos on almost all topics concerning NETs. The very first episode of Luncheon with the Experts, which is July. I'm not even sure what year. Last year, yeah, was with Dr. Maudlin, the creator of the NET test. So if you just go back to Luncheon with the Experts to the first one, which granted is a lot of episodes, that was all that episode was about. So I'm sure you can find some great answers in there. Next question from Melinda. Melinda says, could you go into the POTS, and let's clarify what that is, and the POTS and neuroendocrine connection with carcinoid syndrome?
It's not really a connection. It's just the fact that sometimes patients present with symptoms that are similar to what you would expect with carcinoid syndrome. For example, flushing, diarrhea, abdominal cramping, but have absolutely no evidence of a neuroendocrine tumor after being tested in multiple different ways. And the question is, what's causing that? And in some cases, we've made a diagnosis of POTS syndrome, postural orthostatic tachycardia syndrome, which is basically a disorder of the autonomic nervous system. That's the nervous system that affects not, you know, muscle, not the arms, legs, etc., but the nerves that innervate the gastrointestinal tract, the heart, blood vessels, etc. And so patients will sometimes have other symptoms such as fluctuating heart rate, lightheadedness, And the way to diagnose is with something called a tilt table test. So it's not a well understood syndrome. It's not something that's easily treated, but in some cases, it might explain the symptoms.
Got it. Thank you for that. Next question from Julie. Julie says, after a right hemicolectomy, are there any ways a NET patient can discourage colon bacteria from making their way to the small bowel where they may overgrow, leading to symptoms that require antibacterial treatment? Are there perhaps physical actions or behavioral approaches outside of a low FODMAP diet to control the growth once they take up residence in the small bowel? Did you follow all that?
I don't know. I don't know. I don't think there's a great answer to that. And
Okay.
I certainly don't think, exercise, for example, will make any difference. I mean, a right hemicolectomy basically is a common surgery for removing cancers of the ileocecum, whether it's neuroendocrine or say colon cancer.
Mm-hmm.
But it involves a resection of the ileocecal valve that separates the large from the small intestine. Patients commonly develop diarrhea after that. A lot of that is related to bile salt malabsorption, and there are certain medicines like cholestyramine or cholesterol that can help with that. So that's quite common. Bacterial overgrowth syndrome is less common, but it can happen. And often a gastroenterologist will be the one to make the diagnosis. Not that common after a right hemicolectomy, but it can happen. I'm just not sure that there's anything that can be done to prevent it. But if you have severe chronic diarrhea after bowel surgery, it's certainly something to consider.
Understood. From Lori, if there's a metastasis to the spine, how is that usually cared for? Is that radiation or what's typically done there?
Right. So I assume you're talking about the vertebra rather than the spinal cord itself. But bone metastases are not uncommon with cancer, including neuroendocrine tumors. And the vertebra among the bones are among the most common. The question depends on many things: how symptomatic it is, whether it's threatening the spinal cord. All these things determine whether you need to target that individual tumor, or whether just to treat it along with the same systemic therapy that you're using for the rest of the disease. And often the best people to figure that out would be a neurosurgeon, a back surgeon, and then the decision again is made whether to operate or radiate. But the two local types of treatment generally are either surgery or radiation.
Understood. Thank you. And thanks for your question. Folks, we got just about 10 minutes left. Nancy says, I've never heard of a NET in the kidneys, but can a metastatic NET cause kidney-related problems? I had a small bowel primary with liver mets and one abdominal lymph node.
NETs can very, very rarely originate in the kidney. It's probably less than 1 in a million situation, and very rarely spread to the kidney. Again, almost unheard of. So generally NETs don't affect the kidney. I mean, it can block the ureter, for example, and cause kidney dysfunction that way. That's not extremely uncommon. And of course, treatments can affect the kidney. PRT has a mild effect on the kidney, but it can affect the kidney. Dehydration that can occur with NETs can affect the kidney. So NETs can affect the kidney in different ways, but generally not through a direct impact on the kidney or spread to the kidney.
All right, thank you. A couple questions about CAPTEM. Marnie says, can you speak to the factors to consider in determining the number of rounds of CAPTEM?
So that's a great question. CAPTEM, capecitabine temozolomide, is often given for primarily pancreatic neuroendocrine tumors. It works quite well. The average time to tumor growth is nearly 2 years. And so the question is, how long to administer it for, especially since patients can often tolerate it fairly well. So there's a debate on whether, if you're responding, whether to stop after a year or continue until progression or to continue until maximal response. And there's not really a great answer to that question. On the randomized phase 2 study, the ECOG 2211 study, they gave it for a year, 13 cycles, but with the option of continuing beyond, which most people didn't. Most people stopped at a year. So we know that a year is a legitimate strategy for patients who are responding. But if the disease is fairly aggressive to start with, you might want to continue longer than a year. And so far, we haven't seen any strong evidence that continuing for longer periods of time puts patients at greater risk of, say, bone marrow complications or things like that. So the duration of treatment is controversial.
And Becky also has a question regarding CAPTEM. She says, is it also true that of a CAPTEM treatment that a second try is less effective?
Yes. So one strategy would be to stop treatment, and then if there's progression in the future, to resume it. But yes, it's like any other treatment, it tends to be less effective on the retry. Although, if there's a decent number of years between the first and second tries, I'd say there's a decent chance of response.
All right. Thanks, you two, for your questions. From Sharon, how often should you have scans after surgery for lung nets?
Yeah, the type of surveillance and interval and duration of surveillance are not things that we have great answers to. It depends to some extent on the grade and stage of the primary tumor. The more aggressive it was, the more likely you are to want to do scans more frequently. If it's just stage 1 low grade, you may not need to do any surveillance at all. But usually, for most neuroendocrine tumors, the guidelines suggest more or less once a year surveillance.
Okay. From Bernadette, is it possible that a gallium scan cannot see tumors? I am no evidence of disease for 12 years, and I have fear of this coming back, which is understood. This is a big, broad question, but what's the likelihood of it recurring?
So there's several questions there. The first is that dotatate scans, whether you're talking about gallium or copper, aren't 100% effective. There are some tumors that don't express the metastatic receptors, but most well-differentiated do, especially if it's a small bowel primary. These scans are generally not recommended for long-term surveillance. What are generally recommended are CAT scans or MRIs as an alternative. Dotatate scans are not part of the recommended surveillance unless there's something equivocal on the scans. How long to do surveillance is another controversial question. We know that neuroendocrine